Welcome to the Bronchiectasis and NTM Association podcast, where we're here to share valuable insight from leading health experts, heartwarming stories from people living with bronchiectasis and NTM lung disease, and the latest in health research and treatment. Please subscribe, follow us on social media, and visit bronchandntm.org to learn more. Just a quick note before we get started. This podcast series is intended for educational purposes only and is not suitable for medical advice. Please consult your medical provider if you have any questions. Many people are told that they have severe asthma or COPD, when in reality, they may have underlying structural lung damage that has never been fully evaluated. In today's episode, we'll discuss how these diseases can overlap with bronchiectasis. We'll talk about red flags that suggest it's more than asthma, when daily mucus and frequent infections become warning signs, how often bronchiectasis is missed in COPD, and why CFTR-related disorders can be underdiagnosed in adults. Most importantly, we'll highlight what patients should watch out for, when to push for tests like CT scans or even genetic evaluations, and how to confidently start the conversation with your provider. If you've ever felt that your diagnosis doesn't fully explain your symptoms, or if your current treatment just isn't working, this episode is for you. You may have overlapping bronchiectasis. So today we are joined by Dr. Basavaraj. So welcome, Dr. Basavaraj. Could you introduce yourself and tell us where you're joining us from?
Sure. I'm Ashwin Basavaraj. I'm Section Chief of Pulmonary Critical Care and Sleep Medicine at Bellevue Hospital Center in New York, and Associate Director of our Bronchiectasis and NTM program at NYU Langone Health. At NYU, we are excited to be part of the Bronchiectasis and NTM Association, the clinical care networks, as a full care site where we offer both general and advanced care for bronchiectasis and NTM patients in New York, and access to clinical trials for those that need advanced therapies. And at Bellevue Hospital, we're also proud to offer advanced care to the public hospital community, and really try to help those that may not be able to get the care that they need otherwise. So happy to be here.
When you have patients in your clinic and you hear them say, I've been seeing a provider for many years and really have not gotten any better, what does that signal to you?
Yeah, it signals that something's not right with the patient. So, what makes bronchiectasis challenging to diagnose in the community is that it can present with a lot of similar symptoms suggestive of some other common conditions, such as asthma and COPD. Patients can have a chronic cough for years. They can have some wheezing, which could be from their reactive airways, from underlying infection and inflammation. And they can have, history that could be suggestive of something like asthma or COPD, such as environmental triggers or smoking. But providers, when they see patients with the cough and wheezing and shortness of breath, one of the first things that they think about is, hey, is this asthma or is this COPD? And they may get treated as such. But oftentimes, as we know, in patients with bronchiectasis, treatments for asthma and COPD aren't enough, right? We don't want to treat these patients long-term with inhaled steroids because there can be underlying infections that go untreated. So if patients are not responding to typical asthma and COPD symptoms and treatments, it should really be an alarm that, hey, something else may be going on. Maybe I should get a CAT scan to see if there is underlying bronchiectasis, or sputum cultures, right? To see if there's an underlying infectious process that's contributing to the cough. So that's really how we should really be thinking about diagnosing bronchiectasis is, if they're really not responding to some of these typical treatments, something else might be going on.
So let's kind of unpack that a little bit further, and let's talk about the overlapping diseases that you just mentioned. So we'll start off with asthma. So when we have asthma, how often do you see patients labeled as severe asthma who actually have underlying bronchiectasis?
It happens more commonly than we think, right? Again, patients may present with the cough and wheeze, and we see this for patients who have underlying bronchiectasis and MAC infection, which can present with recurrent wheezing and cough. But patients may get diagnosed with asthma, they get put on inhalers for years, and their cough and wheezing doesn't get better. And you would expect some sort of improvement with typical asthma treatment for these inhalers, or potentially with, biologic medications if their asthma is severe. But if they're not improving on some of these advanced therapies for asthma, something else might be going on. And really have to go down the route of, hey, is this an infection, a chronic infection such as NTM that's causing these symptoms? Is it bronchiectasis? Should I be thinking about treating this patient a little bit differently than typically, inhalers that are given for asthma?
So for the people listening who have asthma and they've had frequent exacerbations, what would be some kind of red flag signs that maybe they need to talk to their doctor or provider about bronchiectasis?
Yeah. So, when I see a patient with an exacerbation, I'm trying to help differentiate between asthma and a bronchiectasis exacerbation. One thing I ask myself is, does this patient truly have asthma, right? And one thing that really typically goes along with asthma is environmental triggers. Do patients respond differently when they're exposed to detergents and perfumes, or animals such as cats or dogs, or weather changes such as cold air or warm air? Do they have eczema or a history of nasal polyps? That kind of allergic phenotype usually fits with most asthma patients. If they don't typically present with that type of phenotype, it makes you think, hey, this may not be asthma, this may be bronchiectasis, and this may be an exacerbation of bronchiectasis. And there's a specific definition for bronchiectasis exacerbation, and that was published in the European Respiratory Society guidelines, looking at a deterioration in 3 or more symptoms, and that's a worsening cough, worsening, fatigue, phlegm, hemoptysis, and a change in treatment that necessitates, treating those symptoms. Oftentimes, those are antibiotics. So, if a patient's like truly not fitting that asthma picture, and they have, underlying bronchiectasis with worsening symptoms, they really should be labeled as a bronchiectasis exacerbation and treated as such.
So what role is there with steroids in asthma management? So I understand that steroids are important for treating asthma, but they are also something that acts as an immune suppressant. So how does that fit in with the treatment of bronchiectasis?
Yeah, it's a great question. So for patients with asthma, we know that one of the mainstays of treatment is the inhaled steroid. It helps to reduce the inflammation that goes along with asthma. With bronchiectasis, we know that patients may have colonization or active infections where some of these immunosuppressive therapies, such as inhaled steroids, may actually cause more harm than good. And there's been some small studies that have suggested some worsening outcomes in patients who are chronically on inhaled steroids who have underlying bronchiectasis. There is a subset of patients with bronchiectasis, particularly for those that have an eosinophilic predominant phenotype, and that's a type of inflammatory cell that responds to steroids. That type of subset of bronchiectasis actually responds well to inhaled steroids. But if they don't have that eosinophilic phenotype and they have underlying bronchiectasis without asthma, we really should be cautious about these inhaled steroid use, because it could worsen their underlying infectious process that's associated with their bronchiectasis.
So at what point should a patient ask, could there be any sort of structural damage because of my exacerbations of asthma?
Well, when patients have longstanding asthma, we usually think about it as an airways disease, and that can lead to remodeling and scarring of the airways. But we really don't typically expect lung damage from longstanding asthma. In contrast to bronchiectasis, where they can get chronic infections and longstanding inflammation, where they can get lung damage. So that's the key difference. I would think of asthma as more of an airways disorder, and bronchiectasis a little bit more diffuse. It can affect the airways and inflammation, but it also can affect the lung parenchyma in and of itself and cause issues there.
Could you just kind of walk us through when a patient would ask for a CT if they have these reoccurring exacerbations with asthma? When would be an appropriate time?
As early as possible, I would say, to get the CT, because that's really truly how we're going to diagnose bronchiectasis. So, if patients don't have typical symptoms or signs suggestive of asthma, if they have a cough that's not improving, we want to think about chest imaging early. We can get a chest X-ray, but we know that chest X-rays often miss, even mild or moderate forms of bronchiectasis, and really, CAT scans are the gold standard to help diagnose bronchiectasis. So, if they're not improving with typical asthma management, or if they're not having the typical presentation of asthma, they really should be vouching for an early CAT scan to see if there's any sort of underlying bronchiectasis that could be contributing to their symptoms.
To help our listeners kind of understand that a little bit more, would you say, like, if you had an exacerbation from asthma or needing to use your rescue medication more often, would you say like one exacerbation or two exacerbations? Could you give any sort of number to that? Like, what would be a lot that would kind of push them into getting further evaluation? Like, what is kind of normal and abnormal?
Yeah, it's hard to put a number to it. We don't order CAT scans based on the number of exacerbations that patients are having. It's really a lack of response to treatment, right? So if patients are on inhalers, but they still have their cough or they still feel wheezing, they're not feeling better, right? Something else might be going on. And we really should be diving a little bit deeper into what might be contributing. So if something it quite doesn't feel right, if they're still having symptoms, and if they're still, potentially exacerbating, they really should be getting CAT scans. And, the CAT scans can pick up one, bronchiectasis, but two, signs of infection too. So, if patients have signs of what we call mucoid impaction or mucus that's kind of stuck in their airways, or another typical term that we look for is something called tree and bud, where it actually looks like the small airways are impacted with mucus. Those could be signs of infections. And that may lead to getting a sputum culture, right? Which then can help try to define whether there is some sort of chronic infection contributing to their symptoms too. So it's not just diagnosing the bronchiectasis on why getting a CAT scan is important, but really trying to see if there's signs of a chronic infection and whether patients should be getting further evaluations with the sputum culture to help diagnose that.
Yeah.
So switching gears a little bit and talking about COPD. So COPD and bronchiectasis can also overlap. And I was reading the GOLD guidelines. So with the GOLD guidelines, they were saying about 25.6% to 69% of people have overlapping COPD and bronchiectasis. Why would you say that there's such a significant gap in that percentage of people who have it?
Yeah. It's a good question. Again, I think it's because these conditions are used interchangeably where they really shouldn't. With COPD, there's two types of COPD. There's emphysema, which is a structural lung injury where their air sacs are dilated and it becomes very difficult for oxygen to transfer from the lungs into the bloodstream. Typically, you see that in smokers. Patients who have long-standing smoking history can get emphysema. And the other type of COPD is chronic bronchitis, where they have mucus production months consecutively, for years of their life, but again, associated with smoking. So if patients don't have that underlying smoking history, and if they don't have underlying emphysema on their CAT scan, which happens frequently, they're labeled as COPD, but they don't have emphysema on their CAT scan, we really should be questioning the diagnosis. Is this truly COPD? Or can this be potentially something else like bronchiectasis that's contributing to their symptoms? And, again, why it's important to get that CAT scan is one, you can see if a patient has underlying emphysema or not. And two, you can see if a patient has underlying bronchiectasis or not, right? So that overlap could be just because, these conditions present so similarly. It's really important to try to, tease out, what's COPD and what's bronchiectasis.
So when we're thinking about COPD and there's 4 different stages: mild, moderate, severe, and very severe, is there any stage in there that might make a patient more susceptible to getting bronchiectasis?
Yeah, I wouldn't necessarily say there's a specific stage in which patients are at a higher risk of bronchiectasis in relation to the severity of their COPD. Patients with underlying structural lung issues, they can develop chronic infections, and that can lead to inflammation and bronchiectasis in of itself. But there isn't a specific stage where I would say patients are more likely to develop bronchiectasis given the severity of their COPD.
So does the presence of bronchiectasis kind of change the course of somebody's COPD? So if they have this overlapping syndrome, are they more likely to be hospitalized more or have frequent infections?
Yeah, I mean, patients can have worsening outcomes if they have an overlap, and we may treat patients differently. So, for example, with COPD, we may use inhalers such as anticholinergics or long-acting beta agonists. Obviously, smoking cessation is very important. But if patients truly have bronchiectasis exacerbations, we might be reaching for some of these newer anti-inflammatory agents, such as the DPP-1 inhibitors that were approved for the FDA for bronchiectasis, right? So if patients truly don't have COPD or exacerbations from an underlying COPD and they have a bronchiectasis exacerbation, we should be treating infections appropriately with underlying bronchiectasis, but thinking about preventing these bronchiectasis exacerbations with some of the newer therapies that are approved for bronchiectasis and not necessarily used for COPD.
What kind of symptoms in COPD patients should really prompt them to be concerned that this is not typical COPD? Like, when should they start really thinking that maybe this is something else?
Yeah, if I often have patients that come in with the COPD diagnosis that never smoked, but they have symptoms of a cough and wheezing and phlegm, and they get labeled as COPD because they present with those types of symptoms. But I would, the first thing that I would ask is there a significant smoking history? Is there any sort of family history of emphysema? Sometimes there's certain genetic conditions, such as alpha-1 antitrypsin deficiency, that can cause emphysema. And is there any sort of emphysema present on a CAT scan? If they don't have the typical smoking history or family history of emphysema, if they don't have significant emphysema on their CAT scan, I would question the diagnosis of COPD and ask myself, do they have bronchiectasis on their CAT scan? And if the bronchiectasis is significant, should they be treated as such instead of going down the COPD route?
So aside from looking at the CAT scan, are there any specific, would you say frequent infections? So if they get these frequent infections, maybe 3 or more in a year, maybe they have really thick sputum, would you suggest at that point too to kind of think about bronchiectasis?
Yeah, especially if they're not, obviously, if they're not improving with their symptoms, we're going to think about bronchiectasis. But yeah, if they have frequent infections, it's important to get a sputum culture. And if we get sputum cultures positive, typically, that we see typically in bronchiectasis, for example, NTM infection, we should be asking ourselves, does this patient have underlying bronchiectasis? But, if patients are if they're not improving, if they're presenting with frequent, infections, it's important to dive deeper in getting imaging and getting sputum cultures to see if they have the underlying bronchiectasis or to see if they have, a chronic infection that's associated with their symptoms.
And then can you speak about NTM lung disease, kind of define it, and then talk a little bit about how someone could get NTM lung disease?
Sure. So NTM stands for non-tuberculous mycobacteria, which the way I like to explain it to my patients is that it looked like tuberculosis under the microscope, but it's not as contagious as tuberculosis. It is actually not known to be contagious, except for a subset of patients, with cystic fibrosis. But and it's ubiquitous in the environment. It's everywhere, typically in water sources. So common areas that are often quoted are old shower heads, indoor swimming pools, hot tubs, saunas, humidifiers, right? Soil. Classically you would see it in avid gardeners. And most people in the community can fight off these NTM infections, but there are a subset of patients that have difficulty fighting these infections, and they can present with chronic infections, that lead to chronic cough, and fatigue, potentially, weight loss unintentionally if their NTM infection goes untreated. But so that's kind of what an overview of what NTM is. There's different types of NTM. The most common one that we see in the United States is something called Mycobacterium avium complex, or MAC for short, which is a very slow growing type of NTM. Sometimes we don't always treat with antibiotics because it may not present as severe, with significant symptoms, and oftentimes antibiotics, if they are needed, may have side effects that are concerning, and it doesn't always get rid of the NTM infection. A lot of times, if patients undergo successful treatment, there's a high rate of recurrence. And there's also another type of NTM called Mycobacterium abscessus, which presents a little bit more aggressively. So NTM, in a nutshell, is a ubiquitous organism in the environment that some patients are able to fight off, and others, for some reason, are not able to.
And how does that kind of share a relationship with bronchiectasis?
Yeah, so the way I like to think about it is bronchiectasis, in a nutshell, is when the airways are dilated from whatever particular reason. Most common condition that's cited to cause bronchiectasis is a prior pneumonia, but we know that there's a number of other conditions that can cause it. There could be autoimmune conditions, there could be reflux or aspiration or sinus issues that can contribute to bronchiectasis. There could be genetic conditions such as cystic fibrosis or primary ciliary dyskinesia or alpha-1 antitrypsin deficiency. There could be immune deficits as well. But when someone has bronchiectasis and those dilated airways, that can lead to difficulty getting that mucus out of their lungs. Mucus gets stuck in these large airways, and that can lead to chronic infections taking advantage of that. And most commonly, the chronic infection in the US that does take advantage of that is non-tuberculous mycobacteria, NTM. And then that leads to just further inflammation and lung destruction in a vicious vortex or cycle that can lead to further bronchiectasis. So important to really get that mucus out of your lungs to try to reduce the inflammation and the infectious burden that can stay there in patients with bronchiectasis.
So switching gears again, we're hearing a lot more about cystic fibrosis and specifically atypical cystic fibrosis, so CFTR-related disorders. I know this is a newer term. Could you just talk to that a little bit?
So cystic fibrosis typically has been thought of as like a childhood disease, right? Patients oftentimes get surprised when I mention cystic fibrosis as a possibility because they're like, wow, I thought this really is seen in children. But, children are screened for the most severe types of mutations. Only a subset of mutations are checked for in newborn screening. But we know that there could be thousands of mutations that are present in cystic fibrosis, and some of them can cause very mild forms of lung disease. So patients with bronchiectasis, if we're really trying to evaluate what may be causing their bronchiectasis, really should be considered for screening for cystic fibrosis because it might open up some doors to therapies. So when we check for cystic fibrosis, we're really checking to see if there's abnormal mutations that causes abnormal salt concentration, an abnormality in the salt concentration in the airways, which then leads to mucus that gets stuck in those airways and infection. So, if someone has cystic fibrosis, they should have two mutations that are positive with suggestive symptoms of cystic fibrosis. But CFTR-related disorders they don't quite fit the cystic fibrosis phenotype. They don't have two mutations that are positive. They may have one mutation that's positive, but still have signs suggestive of cystic fibrosis. And they may respond to therapies that we typically give for cystic fibrosis. So that's why there's a lot of excitement here for CFTR-related disorders, because these patients might be amenable to receiving these types of treatments that are really beneficial for cystic fibrosis and might be beneficial for our patients with CFTR-related disorders as well.
So you're saying that patients with bronchiectasis could have underlying cystic fibrosis that remains undiagnosed, but if they undergo genetic testing, it could reveal a diagnosis of CFTR-related disorders, which could then explain their bronchiectasis. Do you often experience this in your clinic?
I would say, oftentimes patients with bronchiectasis, we know if they have cystic fibrosis or not if they get screened for it. And most patients with bronchiectasis don't get screened for cystic fibrosis. So we oftentimes don't see patients diagnosed with underlying cystic fibrosis because they don't get it checked for.
How would you check for that?
Yeah, so there's a number of ways to check for cystic fibrosis. We could do a screening test called a sweat chloride test, which checks kind of the salt concentration in the sweat. And when that's abnormal, can be indicative of abnormal salt concentration in the airways. That's a screening tool that we can offer to patients to assess whether they have the possibilities of cystic fibrosis. But to really diagnose cystic fibrosis, you need genetic mutation analysis in the blood. They need a blood test to really check for variants that are known to cause cystic fibrosis. So, so the sweat chloride test could be a screening test for cystic fibrosis, but really the blood test that checks for mutations that are seen in cystic fibrosis is really the way to diagnose it.
What are some of the symptoms that connect bronchiectasis and CFTR related disorders?
Yeah, they could have, similar conditions that are seen in cystic fibrosis, such as pancreatic insufficiency, sinus disease, but they may not have the two mutations that are often needed to diagnose someone with full-blown cystic fibrosis, but can present similarly and may respond to therapies that we give similarly to those with full-blown cystic fibrosis.
So, kind of circling back on this whole conversation, we talked about asthma, we talked about COPD, we talked about CFTR related disorders. So, if a patient has one of these things, what would be some signs, or are there some like red flags that you would just suggest that people kind of look inward and see, I think I need to have a CT, I think I need to have a different conversation? And what would you tell someone who maybe is going to a provider who's really not really interested in kind of doing that type of investigation, or maybe think that's not necessary?
Yeah. So, if patients have symptoms such as a chronic cough that's not improving, and we know, chronic cough can oftentimes can be from asthma or COPD, it could be from reflux, it could be from postnasal drip. But if they have a chronic cough and, symptoms that are not suggestive of any of those conditions or not improving with those treatments, we want to think about, is there something else going on, such as bronchiectasis? If they have frequent infections, frequent pneumonias, it could be a sign that they have one of these chronic infections, such as NTM infection, that's not being treated appropriately, and they really should get screened for that with a sputum culture or a CAT scan. And there's some, day-to-day symptoms such as chronic fatigue, and that can present with chronic infections and bronchiectasis. And if patients are just not getting the answers that they really are looking for, and if they still feel like they have these symptoms or other symptoms, they really should be advocating to dive a little bit deeper and mention to their pulmonologist or to their primary care provider, hey, is it possible that I have bronchiectasis? Should we check for it with the CAT scan, and really try to advocate for themselves in that.
What would be something that you would want every pulmonologist or every patient to know about these overlaps?
Yeah, I think we want the community to keep an open mind, and to think about bronchiectasis as a possibility for their patients. Right? It's important to obviously to treat asthma appropriately, to treat COPD appropriately, but really think about bronchiectasis or NTM when patients are if they're not getting better, or if they don't fit the typical phenotype of asthma, or if they're not, a smoker and they're being labeled as COPD, keep an open mind and think that, hey, this could be something else, such as bronchiectasis, that's contributing to their symptoms. Maybe I should, evaluate for that to see if that's causing their symptoms.
Yeah, well, thank you so much for joining us today, Dr. Basavaraj. It was really a pleasure to have you.
Thanks so much for having me.
Thank you for tuning in to the Bronchiectasis and NTM Association podcast. We hope that you found today's episode helpful and inspiring. You can stay connected by joining our online community, following our social media, and visiting our website for more resources. And of course, subscribe to this podcast and join us next time for more insights, stories, and tips to help you live well with bronchiectasis and NTM lung disease. Until then, thanks for listening and be well.